Welcome all. Thank you for joining us for another webinar. Many of you joined us for our last webinar, Disability Identity and Pride and Equity Within Research. We're so excited that many of you have joined us again for another webinar. To those that are new to the CLEC, welcome. We'll be getting started shortly. We'll be awaiting a few moments to allow folks a moment to sign on and get settled. We are so excited for today's webinar, Community Living Equity Centers webinar, HCBS Equity at a state level. We are so excited for this webinar and looking forward to hearing from 3 organizations from 3 different states about how they're evaluating HCBS data. It's such a joy to be in this virtual space with you and to be surrounded by so many amazing advocates, research staff, data scientists, and many others that share in our commitment to equity. To those that don't know me, hi, my name is Jennifer Lee Ramboros, and I'll be moderating the webinar today. I am a brown-skinned Black woman wearing a puff in her hair, a natural haired puff. I have multicolored glasses and a sage color top. Within the Lurie Institute, I serve as a qualitative researcher, exploring community living outcomes amongst persons of color, receiving home and community-based services, also known as HCBS, and LTSS, long-term services and supports. And as CLEC project coordinator, I lead our knowledge translation, technical assistance, and aid in authentic relationship building amongst center partners and diversified stakeholders. Next slide, please. To ensure that all attendees can enjoy the content of today's webinar, we'd like to spend a few moments just covering some accessibility features. By clicking on the interpretation icon, you'll be able to view live ASL interpretation. And by clicking on the CC icon, you can enable Zoom closed captions. Both are located within the meeting control bar. We'll offer a moment for folks to enable their needed accessibility. If you need assistance on how to access these accessibility features, please indicate assistance within the chat. I would like to also offer a huge thank you to our communications team, CLEC Director Teresa Nguyen, as well as many Lurie staff that are here helping to support the event today. And a huge welcome to our amazing distinguished panelists. Next slide, please. Thank you. Our work within the Community Living Equity Center is funded by the National Institute for Disability and Independent Living and Rehabilitation Research, also known as NADLR, within the Administration for Community Living, the U.S. Department of Health and Human Services. Please note that the contents of this webinar do not represent the policies of NADLR, ACL, or HHS, and you should not assume endorsement by the federal government. The opinions shared today are the perspectives of our distinguished panelists and do not reflect the opinions of our funders. Next slide, please. I'm going to briefly cover our objectives for today, as well as our agenda. Little is known about how HCBS impacts disabled persons of color, and we at the Community Living Equity Center are thrilled to feature 3 organizations within 3 states that are beginning to examine equity within their HCBS systems. Our objectives today are to develop shared understanding of how the CLEC seeks to generate detailed new knowledge about participation disparities in community living, discuss disparities within existing data sets and barriers to HCBS data collection, and learn from representatives from New Disabled South, University of Minnesota, and Colorado Department of Healthcare, Financing, and Policy. We'll begin with a brief CLEC overview and mission, then discuss HCBS data disparities, We'll move right into our panelist presentations, and we'll end with closing remarks. Our goal within the Community Living Equity Center is to address gaps in knowledge about inequities in community living and participation experiences and outcomes faced by disabled people of color, and develop interventions to address equity by leveraging existing and new data sources, developing new policy and system change initiatives, and provide active dissemination of findings and trainings for stakeholders. Within the center, we have 3 aims: to generate detailed new knowledge about community living and participation disparities. Aim 2, to develop new or locate available systems change initiatives or other promising practices for reducing community living and participation disparities. And lastly, aim 3, to serve as a national resource for the conduct of disability and rehabilitation research within community living and participation domains that is inclusive of people with disabilities from traditionally underserved backgrounds. I would also like to note that our work could not be possible without our amazing National Advisory Committee, our many CLEC partners, our work group, and our lived experience experts that work along our side in all 5 of our research projects. Thank you. Existing data disparities. Existing data makes limited reference to racial and ethnic disparities in the use of self-direction and also impacts on community living outcomes. We within the Community Living Equity Center are just striving to address equity. And we're also excited that we will be displaying a data dashboard in 2024. Please stay tuned for more information. If you already haven't bookmarked our website, please do so you don't forget that amazing announcement. And also, existing literature doesn't already speak to race and culture consideration and impacts of access and service utilization adequately amongst persons of color with disabilities. And while research has been conducted on how people of color access, use, and experience, and also are affected by education, healthcare, employment, and other systems, little's done to understand how racial and ethnic disparities are prevalent within community living. Lack of data hinders the development of inequitable policies and effective interventions. And while we continue with our research of LTSS and HCBS inequities, we are excited to hear and learn from 3 distinguished panelists. Within the CLEC, our ultimate goal is to address equity and to improve access to HCBS and community living outcomes for people of color. We will move right into our panelists' presentations. We'll be beginning with Kiana Jackson with her presentation titled Uncovering Disparities in Georgia's HCBS Waiver Waitlist. Kiana, the floor is yours.
Good afternoon, everyone. Next slide. Good afternoon, everyone. My name is Kiana Jackson. I am the Director of Data and Research at South Arts and Disability Justice organization that covers all 14 Southern states. We are in the process of examining HCBS waivers across all states. We started in the state of Georgia. As Jennifer stated, the title of work was Uncovering Disparities in Georgia's Home and Community-Based Server Waiver Waitlist, specifically looking at racial disparities. Next slide, please. At the start of this project, we will once again focus on access and utilization challenges faced by different racial groups within the state.
Kiana, so sorry to interrupt. Your audio is breaking up a little bit. It might help if you turn off your video. Do you mind if we try that just so we can hear you more clearly?
Yes. Can you hear me now?
Yes, it seems better. Thank you.
Okay, thank you so much. So, and in this report, so we wanted to focus on access and utilization challenges faced by different racial groups, particularly Black and African Americans. And our report analyzed data, identified contributing factors, and proposed solutions to foster an more equitable HCBS system. Next slide, please. So at the start of this, in order to get the data that we needed, we submitted a FOIA request for the wait list, which took us about 2 to 3 months to get. And then we also later on submitted a request for the recipient list, which took about 2 to 3 weeks for us to get. We conducted some exploratory data analysis at the beginning just to see what information we were working with, and to disclose that we did have to transform some of the data, and that transformation was the information that we got specific ages for each person. And we just took those ages and turned them into age ranges. Next slide, please. For the majority of our comparative analysis, we focused on racial categories that constitute a proportion exceeding 5% of Georgia's population and more than 10% of the state waivers recipient or wait list. As a result of the existence of an additional category labeled as unknown and refused, which met the criteria that we set, our attention was directed solely towards Black and African Americans and white and Caucasian individuals within the state. Next slide, please. So some initial results that we got was that we saw that among Georgians with intellectual developmental disabilities who possess a Medicaid waiver, around 69% are beneficiaries of the comprehensive waiver program, and 31.4% are enrolled in the NOW program. The difference between those two programs are that the comprehensive waiver are for those with more extreme needs, and the NOW program are for those who have more community home-based needs, and they may not need round-the-service care. And those on the wait list for a waiver, we saw that 99% of individuals on the wait list are awaiting a NOW waiver, and only 1% are waiting on a COMP waiver. Next slide, please. So when we started looking at the racial disparities, we conducted a disparity analysis and found that there was a 15.28% disparity between Black and white individuals who are on the wait list versus those that are receiving a waiver. And that 15.28% disparity is in favor of white recipients. Next slide, please. So we wanted to dig more into the racial component of the wait list, but also how long are individuals actually on the wait list. And what we found was that more than 60% of the individuals on these wait lists have been on them since 2019 or earlier, and at least 4,213 individuals requiring HCBS services have been underserved for a period of at least 4 years. We have talked to individuals within the state, and some people have actually been on these wait lists for 19 years, some 16, 15 years. But the data, we could only go back, they only gave us the data going back to 2019. And so that's how we drew that conclusion. Next slide, please. So we also wanted to look at the racial composition of those that are actually on the wait list. And we found that there are around 28% more Black Georgians awaiting waivers compared to their white counterparts. Numerically, that looks like 2,671 Black people are waitlisted versus 1,996 white individuals that are waitlisted. Next slide, please. We also wanted to look at disparities that exist between age ranges of these two groups. So we saw that around 12.7% of those on the wait list are minors within the state of Georgia. So individuals that are under 18. Black individuals have a higher number of people on the wait list compared to their white counterparts. And we kind of saw that on the last slide. There were significant disparities between certain age ranges. So within the age groups of 25 to 34, there is a 44.5%. There are 44.5% more Black Georgians in that age range on the wait list. And between the age ranges of 34 to 44, there is a 67.6% gap between Black and white waitlisted individuals. Next slide, please. Continuing to look at the age range prevalence on the wait list, we found that white individuals account for a significantly higher percentage than Black recipients. For those same age ranges that we looked at in the last slide, where Black individuals were about 44.5% more prevalent on the wait list. For that same age range of 25 to 34, on the recipient list, there are 13% more white recipients on the wait list. On the recipient list. And then same thing for the age range of 34 to 44. On the wait list, there were 67.6% more Black individuals that were waitlisted. However, on the recipient list, there are 4.5% more white people. And then we wanted to note specifically that in the age range of 18 to 24, there is a 40.63% advantage for white recipients. And conversely, for that same age range, Black people are the majority on the wait list with an 11.4% difference. Next slide, please. So then we wanted to look at which waivers were more favorable to each community. So what we saw was that among those that are on the Now and Comp wait list, there are more Black people on the Now wait list and on the Now recipient list. And the opposite is true for white recipients when it comes to the comp wait list and the comp recipient list. So when we're looking at these numbers and we see that there are 99% of those waitlisted are on the Now, are waiting on the Now waiver, we see that that is having a disparate impact on Black communities because Black people are more favorable or more likely to be approved for a Now wait list, a Now waiver. Next slide, please. So we wanted to look at what were some solutions that we could offer to our state in order to address this disparity. So we wanted to start with the fact that going into the fiscal year of 2024, Georgia has an accumulated budget surplus of $10 billion. And these are, of course, funds that are left over after the government has accounted for all of its expenses. We had two major asks. When we originally went into this work, we requested for the state of Georgia to fund 2,400 waivers, and that is amounted to $65 million, and to raise the pay for direct service providers, and that pay would have been a minimum of $18 an hour. And currently in the state of Georgia, they are only paid $10 an hour. So we wanted to we asked for an increase in pay to at least $18 an hour, and that would have been an estimated total of $91 million. And that total was $156 million, and that is still less than 2% of Georgia's budget surplus. What we got is the state allocated $15 million to fund approximately 1,000 home and community-based service waivers, which was a third of what we requested, and less than 0.2% of the state of Georgia's budget surplus. We really wanted to highlight that going back to the pay of direct service providers, a key issue that we see is that even those who are granted a waiver, they have problems or have issues actually finding someone to provide the services that the waiver gives them funds to receive. And this is largely because of the pay that our direct service providers are being paid right now. Next slide, please. Thank you.
Thank you, Kiana, for that amazing presentation. We now will be moving to our next set of speakers, which will be, the presentation is entitled Understanding Equity in Colorado's Home and Community-Based Services. We'll be having Liana Major, as well as Tasia Sin, who are joining us from the Office of the Community Living at the Colorado Department of Healthcare Policy and Financing. The floor is your walls. Thank you.
Thank you. Thank you all for letting us be here and for CLEC of putting this event on. It's so exciting to hear what other states are doing and hopefully get to engage a little bit in some questions. So as Jennifer mentioned, I'm Tasia Sin. I'm a senior policy advisor in our Office of Community Living. And I focus more on strategic planning, communication, and stakeholdering. And then Liana Major, she works in our research and analysis office, and so she's joining me to talk about the research we did. But before we do that, let me just introduce our project a little bit. Next slide. So the goal of our project, which was funded by the ARPA initiatives, the American Rescue Plan Act money that infused all of us states with a lot of funding to kind of dive into HCBS and help support that system. So we were funded by that, and our goal is really to help us better understand who receives home and community-based services in Colorado, what services they receive, where there are gaps, and really try to target outreach to ensure that our Medicaid programs are appropriately serving all Coloradans who qualify. There were 3 phases to this work. There was an internal data analysis and literature review, and Liana will go through the data analysis piece. And then there was external stakeholder feedback and recommendations, and I'll go through a little bit about that process. And then the last phase is implementation planning. So we're in that phase now. There's a link. When Liana's talking, I'll dump the link in the chat because I forget that Zoom, you can't click on the link. So there's a link to our webpage that has the studies. So I just wanted to note that here ahead of time, and I'll put it in the chat and then send you to that again at the end. So next slide. With that, I'm going to turn it over to Liana to talk about our research analysis.
Thank you, Tasia. So this first slide really helps set up the way that we were thinking about disparities within HCBS. We developed this little diagram to help us kind of think through how disparities can compound for our Medicaid members who are receiving HCBS services. So I just wanted to spend a few seconds setting this up so you can understand our thinking process. So the outermost ring is prevalence. We wanted to look at who in Colorado is experiencing disability, the prevalence rates of disability by race and ethnicity. We also looked at it by age, obviously, because that's a huge intervening factor. And then we kind of dove in one level at a time deeper. So we spent a lot of time looking at enrollment in HCBS. This is where we ended up spending most of our analytical time because this is where we saw the biggest issues. It's also where our data is the best. We looked at enrollment by waiver as well, and then we kind of dove into utilization of services, HCBS services. And I'll talk a little bit about this. We have a lot more work we did on this that isn't published because we have found that there weren't as many identified disparities here, and that may be also partially due to methodological challenges. But we looked at authorized service hours versus utilized service hours for different race ethnicity groups. And then the last little part of this, which is not so little, is outcomes. And we did not dive into this for several reasons, at least not at this time. Next slide, please. This is just a quick slide showing that we pulled the census data for Colorado to look at disability prevalence by race ethnicity group. And so this is showing, this was meant to give us just kind of a starting point for who we might expect to see receiving our HCBS services. American Indian, Alaska Native, and Black individuals, we were expecting to see higher rates of enrollment in HCBS, so that's what should happen. Same with for older adults, Hispanic, Latino people, and as a spoiler, that is not what we found. So I will get into that next. Next slide, please. So one of our, diving into the actual data that we pulled, one of our biggest takeaways is that our Hispanic and Latino individuals are underrepresented in HCBS services. This is true of both our adults and our children, but the scale is much larger for our children members. So how did we define underrepresentation? This was something we spent a lot of time going back and forth on. What we landed on was that we compared the percentage of people of a race ethnicity group that are enrolled in HCBS to the percent of that group that's enrolled in Medicaid overall. So anyone receiving a Medicaid service. The main reason we did it this way is because Medicaid's acuity thresholds for HCBS aren't comparable to what the census data report. And so, we wanted to have a little bit more accurate of a comparison point there. And then just to mention, one limitation of this approach, of course, is that if there's under enrollment in Medicaid overall for a certain group, then that's going to be underestimated in what we're showing. But that's how we did it here. So all of these light blue lines are HCBS enrollment, and the darker blue lines are enrollment in Medicaid overall. So you can see that the disparities are quite large for the Hispanic Latino population here. And for our white members, it's reversed, where we see more representation by our white members in HCBS than we do in Health First Colorado, which is the name of our Medicaid program. Next slide, please. We also took a look at underrepresentation by language, preferred language. We see that across the board that Spanish speakers are underrepresented in HCBS when compared to Medicaid overall. Interestingly, we actually dug into some of the folks who speak languages other than English and Spanish, and the results were better for that group. And I think that's an area where we hope to look into more about which providers are serving those individuals and what can we learn from that story. Next slide, please. I included this table just to show everyone how we pulled our disparities data. I think this is something that can be replicated by any state Medicaid program. This table shows enrollment in HCBS versus Medicaid overall by race ethnicity group, as well as by age group. This is the underlying data that you're seeing that was on the slide before. We also pulled this and replicated it by HCBS waiver. So we noticed that for certain of our waivers, there was underrepresentation by certain groups, especially in the developmental disabilities and mental health waiver space. And that was another level that we looked at, but that I am not presenting today. One thing just to mention, I don't show member counts here, and that's due to HIPAA, but the next slide, I'll get into kind of why. Next, please. It's particularly hard to look at small populations, and sometimes in our disparities work, we, focus on the larger populations. For Colorado, that's our white, Hispanic, Latino members. However, we did look at raw counts of enrollment in HCBS for our smaller populations, which are our American Indian, Alaska Native, Black, Asian, Native Hawaiian, other Pacific Islander groups. And even though percentages don't work as well here in terms of estimating underrepresentation, the raw counts are telling. For instance, we found there were essentially no Native Hawaiian, other Pacific Islander children enrolled in any HCBS service. For our Black members, there was also small numbers of kids who were in HCBS, same with our American Indian, Alaska Native members. And just looking at those counts, raise some red flags for us in terms of we're not getting enough people access to these services that we think are probably needed. Next slide, please. Geography, as you can imagine, was a huge reason for looking at, a huge contributor to looking at racial and ethnic disparities for many reasons. We learned several things here. I think this is a very complicated story. What we found is that some specific providers, specifically those that are coordinating care for our HCBS members, tend to influence the disparities that we're seeing. So for example, we weren't seeing significant service utilization disparities by race ethnicity group in Colorado. And we believe that is because when we looked at it by service provider, we were seeing that the providers that served most of our Black and Asian members, for instance, were also tended to have higher authorization rates and service utilization rate for those individuals. So that was influencing and mitigating the disparities that we were expecting to see. I think another thing to keep in mind in terms of like underrepresentation is that even in some of the geographic areas that are more racially and ethnically diverse in Colorado, we were still seeing underrepresentation issues. And so that is a problem that is just across the board for our state. Next slide, please. We also took a look at behavioral health diagnoses for HCBS members versus Medicaid overall and found higher rates of having any type of mental health or SUD issue. And so that's an area where we're doing a little bit more work around, but did want to highlight that we looked at the data this way. And then lastly, next slide. As I mentioned, we did a lot of work pulling service authorization rates and utilization rates by race ethnicity group. And we didn't end up seeing substantial disparities there, I think for several reasons. And I think part of those reasons are because underrepresentation was such an issue. So when we have smaller sample sizes for these groups, we might not be seeing differences that might exist in real life. And so one area we did want to focus on here is just the consumer-directed services, which we focused on because these are set up to promote equity in many ways. And we are seeing differences in the rate of service utilization and authorization by race ethnicity. In particular, our Black and Hispanic Latino members are using fewer services than folks in other racial groups. And interestingly, our Black members in particular are more likely to rely on an agency to help them with their attendance services than consumer directed, like when you hire someone directly to come into your home where you manage that person. And so there's a lot to dig into here that we're planning on getting into in the future, but this was one area that jumped out at us as an opportunity for addressing disparities going forward. And with that, I will turn it back over to Tasia.
Thanks, Leanna. So Leanna had shown the slide at the beginning, and this slide is just again to say, we had all of this data, and really when we think about the compounding equity issues, we think representation in programs is sort of a good place to start. And so we did our stakeholder engagement around this representation piece. Next slide. So we worked with an amazing two groups of people, the Civic Consulting Collaborative and CREA Results. So if you are in Colorado, highly recommend them as just general people. They're pretty awesome. And so they designed this engagement plan for us. We did a survey. We got nearly 500 responses, and the survey was really intended to understand from the community, what the barriers and solutions they see for building awareness around enrollment and utilization. Then we had a big summit at the sort of start to kick everything off, and we heard from attendees to sort of deepen our understanding of the things we heard in the survey. And then we conducted learning exchanges, which is what I'll mostly be talking about. And then we had a big summit at the end, and that summit it's recorded online on the website I shared, and it's pretty cool. We had some of the organizations we worked with come and talk about how they do their work and how HCBS would sort of fit in with their work, which will make a little bit more sense after I go through my presentation. Next slide. So we decided to conduct learning exchanges with community-driven organizations. And I'll tell you next what a learning exchange is, but why did we focus on community-driven organizations? So while identifying, with a disability community also has a history of marginalization, people who identify with additional marginalized groups in terms of race, ethnicity, gender, sexual orientation, for example, most often experience even more barriers to accessing services due to the mistrust, stigma, or lack of knowledge. So many of the, and we also know that many of the individuals who are connected to HCBS got there through relationships to people who are in the system already. So, their friends or family or advocacy groups. But what we realized is if your cultural community isn't connected to these formal systems that are connected to HCBS, then you may likely have an even lesser chance of knowing about the programs, much less a chance of knowing how to navigate them. So this is where our trusted community-driven organizations come in. They really hold the social capital in our communities and act as that bridge or broker for their community and the systems that have traditionally excluded them, either explicitly or implicitly. These organizations and their navigators are really experts in their communities, cultures, histories, needs, and opportunities, while also having expert language and understanding of how systems like Medicaid operate. So they were really our great opportunity for us to learn sort of why folks may not be accessing our programs. Next slide. So how did we design a way to kind of talk to these organizations? So what we realized kind of early on was that many of the organizations that we chose to work with didn't even know what HCBS were. And so we designed a learning exchange model where we presented a mutual exchange of information, where we were really sharing what the basics of HCBS were, how people could help their communities connect with HCBS, some really basic information. And then they shared with us sort of how they really champion health equity in their communities in some of these programs like Medicaid. This really created a dialogue of connection and relationships that we're still sort of working on and reaping the benefits dually to really expand our network and understanding the different perspectives, and then hopefully building up this community's capacity to help their folks navigate HCBS. And it was really a space to like talk about resources and future partnership. It was a pretty cool model. So next slide. These are our partner organizations. They're all listed here. We try to get some geographic representation across the state and some representation among some of the more marginalized groups that we saw in the data. So we tried really hard to make sure that we were hearing from lots of communities. Next slide. And so what did we learn beyond sort of some of the basic stuff about HCBS? So we heard a lot about how these organizations really champion health equity. And so these things I think I've carried internally into our department and think about how we're sort of implementing that out in the community. So, they really rely on those authentic personal relationships that are grounded in dignity and respect. Language and cultural justice is a huge part of what they do. They do highly individualized navigation and support across the social determinants of health. And then they have very strong personal, professional connections with other organizations that they really rely on to refer folks when they're really in those vulnerable spots. So they're trusted organizations and relationships. Next slide. So what came out of these learning exchanges was a set of recommendations. We're a state agency, we've got to get recommendations. So the recommendations really surrounded around 4 main themes. I'm going to do them really briefly, but I do have 4 slides in here that go in a little bit more detail if you want to check it out. And there's a great report that the contractor put together that's on the website. So the first one was continuing to elevate trust and relationship building. I think we all recognize as a state agency that perhaps we're not doing the best job of building relationships and trust with communities that have not historically been sort of involved in HCBS. And so we really looked at ourselves as how we can start to build those relationships and trust. And we have agencies that are out in the community, our case management agencies. Colorado has regional accountable entities. We've got people out there who are sort of doing the work on behalf of Medicaid. And so we really see ourselves as a department as an information provider, making sure communities know what's available and how to access it, and a convener and facilitator of relationship developing. So what are our expectations of our contractors out in the community to work with these community-driven organizations and really start developing those deep personal professional relationships. And then also we see ourselves as a capacity builder through these learning exchanges. So building the capacity and knowledge base and resources among community-driven organizations for HCBS. Slide. The second one was integration of HCBS throughout the system. Excuse me. We learned through our conversations that even places like federally qualified health centers in Colorado have no really information or training or really accessible websites or things like that about HCBS. So this one was maybe not new or shocking, but a reminder that not everyone knows about HCBS, and especially in sort of formal systems, there may not be that knowledge. So spreading this HCBS knowledge throughout the system, so including it in certification and training programs that we're expecting of Medicaid providers and navigators, increasing awareness just among state employees and county employees in Colorado. And we have new community health worker legislation where we are formalizing that profession in Colorado, and so embedding HCBS sort of into those expectations and making sure that folks who are working as a community health worker have access to really reliable information about HCBS. Okay, next slide. Trying to go really fast, sorry about that. Responsive materials for resource navigation. So one huge area that's a barrier for navigation and enrollment in HCBS is just materials that are accurate, easy to understand, easy to navigate, and translated into languages that folks speak. So we are working on transcreation and co-creation of materials right now, especially a process map that we will have by the end of the summer, hopefully. And one of the key pieces we learned is that in our current materials, we don't really talk about the financial piece of enrolling in HCBS, and then the things that are available to make sure that folks who are trying to enroll in programs, can still work, have money, those sorts of things. So the buy-in programs we have in Colorado and ABLE accounts. Next slide. And then the last one is accountability. We need to be accountable to equity outcomes. And so that's really, we're looking at how to do that through transparency and then developing standards and evaluation protocols for our contractors that include equity outcomes and community collaboration. And by contractors, I'm using that word broadly, but case management agencies, essentially. Really fast, this is some of the work that's continuing to move forward. We didn't stop there. So we are extending this 3.01, we call it, project, this equity study. And we're going to continue implementing some of the recommendations through the learning exchanges, and also really taking a deeper dive on the community, American Indian and Alaskan Native communities. We're also doing the materials that I just mentioned. We're going to be translating a backlog of materials, and then also making sure that we're tracking materials so that they're in plain language, accessible, and translated. And then we've also launched a series of EDIA workshops for our staff that are, over this year, we're doing 5 full-day workshops. So we're hoping that that increases our capacity as a department to really implement this equity work. Thank you all. I will check the Q&A for questions.
All right. Well, I think it is my turn now. Good afternoon, everyone. My name is Tatiana Shippey. I'm a professor at the University of Minnesota School of Public Health, and just really enjoy these presentations. Such an honor to participate in the important work all of you are doing. And I will be sharing my work from the perspective of a researcher who has partnered with the Minnesota Department of Human Services. We'll go to the next slide. I would like to acknowledge again, the funding for this work was provided by the Minnesota Department of Human Services, who received some of their fundings through Moving Home Minnesota, which is a federal demonstration project through the Centers for Medicare and Medicaid. And then they approached us, my team at the University of Minnesota, to conduct the analysis of the data and other research for this work. I also want to acknowledge my community collaborators, Robin Fraser, Elena Wright, Adia Kosionu, who was a research assistant on the project, and Trisha Scarpel, who was a project manager and I know is listening in today. Next slide, please. So what I'm hoping to do, I know we don't have a lot of time, so we'll try not to rush and maybe we can skip over some slides, is just to share with you big picture some of our findings in Minnesota regarding areas for improvement in promoting racial equity in home and community-based services and some of the solutions that came up or recommendations from our work. I think you will see that there is a lot of actually overlap in what was shared before, especially by folks from Colorado. So it's exciting to see some of the similarities in our work. Next slide, please. So this project, when we started it in 2019, overall had 4 broad goals. One was to examine racial and ethnic disparities in home and community-based service programs with a specific focus on the assessment process. Then my work as a researcher was to conduct quantitative and qualitative research to understand and measure these racial ethnic disparities in the assessment process. And then broadly, DHS's goal is then to champion ongoing measurement to monitor disparities over time, as well as inform policy and operational changes. Next slide, please. So what we actually did for the results I'll be sharing with you, our goal was to, as I said, analyze racial ethnic differences in the use of home and community-based services for adults in Minnesota. And our goal was to use mixed methods, quantitative and qualitative methods to do that. We also assembled a statewide community advisory board to guide this work, and I'll share about it a little bit more in a minute. And the work took place from the specific results I'll be sharing are from 2019 to the end of 2021. Next slide, please. As one of the first steps in our work, we conducted a literature review to understand what do we know from the literature on racial ethnic differences in use of home and community-based services. And big picture takeaways, because I think you already heard much of this from other presenters, is one, this is so much smaller body of literature compared to the work that we have on nursing homes, for example. And some of that is because, a lot of it is because we just don't have the data. So I think the lack of data, and especially data around racial ethnic differences, is really a key barrier that should be addressed. But from the literature that we do have, we do know that it does show that there are commonly identified barriers in access to HCBS, which include lack of knowledge about available services, organizational barriers, and you heard about this, about wait lists and lack of referrals, communication difficulties, geographic barriers, as well as cultural misalignment of services. The literature also showed that quality of care was higher in areas that were primarily white, sort of that zip code disparity compared to quality of home care, for example, in primarily areas that had a high proportion of Black, Indigenous, and persons of color. And as I said, all in all, it is a small body of literature. And for me as a researcher, I guess one of my goals here and takeaways is that we must be advocating and looking for other sources of data to do this work, because it should be done. And I appreciate what this coalition is doing on that. Next slide. So as I noted, this was a mixed methods project that included quantitative and qualitative data analysis. And my team led the qualitative arm of the study. And what I will do in, I guess, the time we have remaining, I'll prioritize the results from the qualitative findings. And really, as we heard from Kiana's presentation earlier, disparities may arise at any point in a process, right? In the assessment process, enrollment, and utilization. And what the quantitative data showed us in Minnesota, and we could share more of that for those interested, is that indeed there were racial and ethnic disparities in the assessment process, but sort of the trends for that were varied. It differed by racial ethnic groups and the types of services assessed. And what we tried to do with the qualitative data was to understand what is causing the disparities that we saw from the quantitative analyses. And so to do this, we assembled a statewide advisory board consisting of 22 individuals from diverse racial ethnic backgrounds. I was really impressed and excited to receive hundreds of applications across the state of folks interested in serving on this board. And we just tried to be really intentional to ensure that there was racial ethnic representation from different parts of the state, and inclusion of folks across the life a spectrum of different ages on our board, and you will see that 9 individuals were African American or African heritage. Additional 1 person was an American descendant of slavery, 4 were American Indian or Alaskan Native, 3 Asian, 2 Hispanic Latino, 1 person who was Middle Eastern or North African, and 6 white non-Hispanic. Many of them were from the greater Minnesota area, and these folks really worked with their communities, and many of them were representing different groups to ensure that the feedback they provided for us was inclusive of their stakeholders for the groups that they were representing. And so we'll go to the next slide, please. So what I will do here is just broadly describe the 4 key findings from this work that merge quantitative and qualitative results together. And first was that there was a lack of access to information, services, and funding for people who are Black, Indigenous, and persons of color, and those from rural communities. We saw that from our quantitative data, and we certainly heard this from our qualitative results. And as this quote from one of the advisory board members, I think describes this well. They said, "People cannot access what they do not know about. Building culturally sensitive relationships with multicultural communities and organizations will help promote trust and community collaboration between DHS, the Department of Human Services, and other stakeholders, mobilizers, and other key actors in the community." And we heard a lot about this lack of access to information. Second finding was that long-term services and supports overall, and HCBS as part of long-term services and supports, are not culturally inclusive, and that there are service gatekeepers who perpetuate bias and stereotypes. And so some of folks in our qualitative work talked about the bias that they experience from assessors and just overall lack of awareness on cultural humility. Again, a quote from one of our advisory members who said, "We're not getting a lot of help or explanation at the county level. A lot of Native and Indigenous people don't understand how to navigate new and changing systems." I think these service navigators made things very difficult to understand, even if they were explained at the county level. A third theme, and this was pretty broad, pertained to stigma in the Black, Indigenous, and other communities of color that are associated with use of LTSS and HCBS utilization in particular, especially for mental health needs. As one of our members said, people in many African immigrant communities do not want to openly talk or accept help with disability. There is some level of stigma with many African immigrant communities on this. They talked about submitting work to especially work with Somali community around these issues, but we also heard it from East Indian communities and other minoritized communities in our state. And finally, our fourth finding pertained to historical mistrust of government related to limited capacity and competency in addressing the health needs of individuals from communities of color and other marginalized communities. I think this quote summarizes it well, where advisory board members said, "So whether people know about the services or not, they're not built for them. If they're not built for them, it doesn't make any difference. There is also the lack of having things in other languages so that people can gain the knowledge that they need in other areas." And now I saw Teresa unmuting and coming on. I know that we are short on time. Would you rather I stop here so you can provide closure for the meeting? Jen and Teresa, let me know.
Go ahead, Tatiana. I think we have a little bit.
All right. Well, based on these findings, let's go to the next slide then. We have 3 key recommendations. I think, again, these are very much consistent with what was shared by folks from Colorado and Georgia. So it's good to see that we are kind of aligning along these. Our first recommendation was the need to make HCBS services more person-centered. And these include the following: the need to increase just awareness of existing HCBS services to those in communities of color, the need to reduce state bureaucracy and paperwork required, the need to combat stigma for receipt of services, especially for mental health. We heard a lot about this. The need to identify barriers to HCBS to specific cultural communities, and the need to build meaningful partnerships with communities that serve individuals who are Black, Indigenous, and persons of color. Next slide. A second recommendation focused on the need to diversify, equip, and support HCBS providers. Many of our participants talked about the need to increase diversity of HCBS providers, to provide training on culturally sensitive care and cultural humility. That's where we heard about the bias among assessors and other players in that space. The need to support community providers who already serve BIPOC communities, including addressing pay, high rates of staff turnover. Many caregivers talked about the incredible stress of the high staff turnover and the need for system-level solutions to address it. Next slide, please. A third recommendation and final recommendation really focused on the need for system-wide change. And that includes creating opportunities for integration for older and younger adults, which often are so segregated, creating requirements and/or incentives for cultural competency training of providers. We heard from providers who said, we want to do it, but we need resources to do it. Adapting greater use and coverage of telemedicine and technology services, especially for those in greater Minnesota and other areas that are more rural, and having people from specific racial ethnic groups actually driving the design of programs and implementation. And with that, thank you so much for your attention, and I look forward to answering any questions you might have in chat. Thank you.
Thank you, Tatiana. So many amazing points that resonate with the work that we're doing within the Community Equity Center. The importance of engaging community, as well as the importance of recognizing cultural considerations. To our panelists, thank you so much for your time, as well as your expertise. Collectively, you all have spoke to many themes that align within our work in the CLEC, and many themes that come out within our interactions with our partners, including gaps in service utilization, gaps in knowledge regarding HCBS programs and supports, as well as underrepresentation by folks that are Black, Latino, or of color. We thank you for sharing this space with us. As we wrap up, for those that may have questions related to the CLEC or questions regarding HCBS data, or if you'd like to stay connected with us on our quest for equity, feel free to email us at clequity@brandeis.edu. And don't forget to bookmark our website if you haven't already, so that you can check out our previous webinar as well as this webinar recording at communityliving.equity.org. Recordings will be shared with webinar attendees. Thank you to those that attended, and we will see you soon. Bye.